First and foremost, thank you to Adrian Newland and the ITP Support Association for inviting me to talk about ITP in pregnancy. I'm a haematology doctor working at Guy's and St Thomas's, and my clinical practice includes obstetric haematology, looking after women with blood-related diagnoses in pregnancy. So ITP in pregnancy and thrombocytopenia, low platelet counts in pregnancy. We know that there is a natural decline in the platelet count in all pregnancies. However, platelet counts less than 100 are only seen in 1 in 100 women in pregnancy, and counts less than 80 are only seen in 1 in 1,000 in the absence of another cause. Immune thrombocytopenia is one of many causes of low platelet count in pregnancy, and women may have a prior diagnosis of ITP or be diagnosed with ITP in pregnancy. In women with a prior diagnosis of ITP, it is most likely they will have had a chance to discuss pregnancy plans with their haematologist. Women diagnosed in pregnancy are likely to present following blood tests they've had done with the GP or the midwife at their pregnancy booking visit, or later in pregnancy if they've had bloods taken at 20 weeks or beyond, or in the event of any symptoms in pregnancy, including any bruising or bleeding. Some of the challenges of ITP in pregnancy are preventing bleeding in the antepartum, intrapartum, and postpartum phase, and preventing thrombosis, because we need to remember that ITP, as well as being associated with bleeding, is paradoxically associated with thrombosis, actually being a sticky blood disorder as well. We also need to balance the risks and benefits of treatments and potential side effects in pregnancy. So prior to pregnancy, if possible, there should be a meeting with your haematologist to discuss your ITP, what medications you're on, and provide you with details of the team available in pregnancy and proposed management for the antepartum and postpartum phase. When we look at treatments prior to any pregnancy, any medications that are contraindicated in pregnancy should be discontinued. An alternative treatment may need to be commenced. In pregnancy, up until 34 to 36 weeks, if there's no evidence of bruising or bleeding, no planned procedures, a platelet count of 20 to 30 is generally considered to be safe. From 34 weeks, the team will aim to maintain a platelet count above 50. When treatment is required in pregnancy, first-line treatments are steroids or immunoglobulin. Frequency of follow-up in a pregnancy clinic will depend upon your individual requirements, symptoms, and platelet count, and any treatment that's required. The haematologist will work closely with the obstetricians, midwives, fetal medicine colleagues if required, and anaesthetists to ensure a multidisciplinary approach. Each clinic will include a review of any symptoms, current platelet count, discussion re any treatment required, and discussion about how pregnancy is progressing and what preparation is required. So has COVID impacted our clinical model of care? I would say yes, it has. We have reduced unnecessary face-to-face appointments, but we've also tried to make every contact count. So full blood counts will be taken at midwifery appointments, obstetric appointments, and at planned scan appointments. There is also access to community phlebotomy if required, and the majority of consultations may be provided by telephone or video consultation, but there is always access face-to-face as and when required also. So what if steroids or immunoglobulins don't work? There's the option to try combined therapies with prednisolone and immunoglobulin, or alternative treatments with steroids or immunoglobulin. Azathioprine and other immune suppressive drugs listed are considered safe in pregnancy, may be continued or commenced in pregnancy as necessary under the guidance of a consultant haematologist. Drugs to avoid in pregnancy that may potentially harm the unborn child should be avoided in pregnancy. Where additional immune suppression is required in pregnancy, azathioprine is generally considered safe and well tolerated. The unborn child also lacks the enzyme required to convert azathioprine to the active drug form. However, limitations with azathioprine include the fact that it may take 6 to 8 weeks to have full effect. So are there any other possible treatments? Rituximab can be considered in pregnancy in refractory cases. However, this may result in a temporary reduction in the newborn's immunity and potentially increase susceptibility to infections. And what about TPO agonists? These may be considered in exceptional circumstances, although data regarding the tolerability and toxic effects on the fetus are limited to recent case studies. However, these case studies so far show a good response and safety profile. So with regards to preparation for delivery from 34 weeks onwards, the treatment goal is to achieve a minimum platelet count of 50 for delivery, and the platelet threshold for epidural in most cases is 70. Senior anaesthetists, however, may consider an epidural in certain circumstances with a platelet count greater than 50. All women should also be risk assessed for thrombosis, which is a standard of care in all pregnancy management. There is a small chance babies born to mothers with immune thrombocytopenia will have a low platelet count temporarily. However, major bleeding is uncommon. The baby's platelet count may fall further in the first few days after delivery, and a second baby platelet count may be required. There is no correlation, however, between the severity of maternal ITP and the baby's platelet count. ITP should not alter the maternal and women's services team decision around mode of delivery. There is no evidence caesarean section is safer compared to vaginal delivery. However, fetal monitoring with scalp electrodes, blood sampling, ventouse, and rotational forceps should be avoided. And a cord blood platelet count is taken at delivery to determine the baby's platelet count. So this slide summarizes the management approach. So first and foremost, making the diagnosis of new cases of ITP in pregnancy, and then considering treatment options according to the gestation of the pregnancy, and maintaining platelet counts above 20 to 30 up until 34 to 36 weeks, and then aiming for a platelet count of 50, and management to ensure the neonatal platelet count is checked, and if additional monitoring is required, this is available. At the time of clinics and follow-up and in preparation for delivery, the haematologist and obstetrician are likely to provide a treatment plan or letters, and in addition, a delivery plan for women with ITP in pregnancy. So moving on from pregnancy management, I wanted to just highlight in addition the pregnancy arm of the ITP registry, which has been open since 2018. This arm is open to pregnant women diagnosed with primary ITP prior to or during pregnancy. To date, 31 women have been recruited, 26 have delivered, and we have complete data sets for the first 21 patients. The median age is 33, and different ethnic backgrounds are represented. As you can see, the average platelet count is 59 in pregnancy and 111 at delivery. 8 of the 21 women did experience some bleeding during pregnancy, and the challenge of the registry is to collect further data into the detail of the bleeding in these cases, including some missing data fields that need to be reported. 8 of the 21 women also required treatment in pregnancy, and as we can see, the majority of these treatments were steroids or immunoglobulin, and in one case, romiplostin and azathioprine. With regards to delivery, 11 of the 21 had a caesarean section. There was one platelet transfusion, and free reported postpartum hemorrhages. So this is really the beginning of the pregnancy arm of the registry, and this study will hopefully provide invaluable data on the management and outcomes of women with ITP in pregnancy to help better risk stratify women as they head into pregnancy. Pregnancy in ITP is a rare overall occurrence, and using the pre-existing infrastructure of the UK ITP register has allowed a linked data set to further our knowledge in this area. Thank you.